and Director of the National Virus Reference Laboratory and NEFIT member. And from the Department of Health, we're being joined in Committee Room 1 by Dr. Alan Smith, Deputy Chief Medical Officer, Dr. Murish O'Connor, Assistant Secretary, Research and Development and Health Analytics Division, and Ms. Laura Casey, Principal Officer in the Department of Health. I wish to advise the witnesses that by virtue of Section 17(2)(l) of the Defamation Act, witnesses are protected by absolute privilege in respect to their evidence to this committee. If you are directed by the committee to cease giving evidence in relation to a particular matter and you continue to do so, you are entitled thereafter only to a qualified privilege in respect of your evidence. You are directed that only evidence connected with the subject matter of these proceedings is to be given, and you are asked to respect the parliamentary practice to the effect that, where possible, you should not criticise nor make charges against any person or entity by name or in such a way as to make him or it identifiable. We expect witnesses to answer questions asked by the committee clearly and with candour, but witnesses can and should expect to be treated fairly and with respect and consideration at all times in accordance with our witness protocol. And if you have any concerns in that regard, I would ask that you raise them immediately. Professor Mallon, can we have your opening statement, please? And as customary at this stage, I'd ask that you confine it to 5 minutes, as it has been circulated in advance. Thank you, Professor Mallon.
Thank you, Mr. Chairman. I'd like to thank the Chair and the Committee for inviting me to appear today and for the opportunity to make this opening statement. Ireland is making steady progress in emerging from the first wave of Covid-19 pandemic that has caused a significant number of deaths and damaged our economy, the education of our children and the provision of healthcare. Ireland has arrived at this point largely due to the unprecedented support, sacrifices and actions of the Irish people at the request of the government following advice of public health officials. The Irish people have chosen this path at considerable personal cost, primarily to protect the lives of their family and fellow citizens. As a result, Ireland now holds the advantage in our war against the SARS-CoV-2 virus, with the potential to maintain infections at an absolute minimum. It is vital that we do this properly. We are only now beginning to understand the impact of this first wave on the health of our citizens. There is no effective pharmaceutical treatment or vaccine to prevent acquisition or spread of this infection. In addition to the large number of deaths we have witnessed in Ireland, as highlighted earlier this week to this committee, many of those affected, even young and healthy individuals, experience considerable morbidity and prolonged recovery times. Accepting any level of ongoing community transmission puts people's health at risk and will further hold back economic recovery. Ongoing community transmissions, such as that seen in the United States, Sweden, parts of the United Kingdom, together with resurgence of cases in Lisbon and the outbreaks reported in Germany, serve to highlight that Ireland is still very much within a geographical high-risk zone for Covid-19. I and others in the infectious diseases clinical community believe that it is inevitable that we will experience a resurgence of cases as we relax restrictions and permit more travel. In this context, control of SARS-CoV-2 virus within our communities through a highly effective programme of rapid testing, contact tracing and community actions becomes a priority in maintaining our national biosecurity. Effective community control permits a more stable and meaningful economic recovery, recovery of education for our children, recovery of our health services, including vital screening services, and restoration of quality of life and improvements in mental and physical well-being. In many ways, this programme becomes the beating pulse of our country. At the present time, as society opens again, the Irish people are handing back some of the responsibility for controlling SARS-CoV-2 in Ireland to the state. If this programme fails to work effectively, we risk losing the gains provided to us through the sacrifices of the Irish people. Both infectious diseases physicians and leading figures within the Royal College of Physicians in Ireland have called for a written, detailed, coherent plan dealing with control of the SARS-CoV-2 virus on the island of Ireland. This should include a detailed end-to-end testing and contact tracing plan, embedded with rapid turnaround times and clear key performance indicators. Alongside this, greater investment during the coming weeks to rapidly upscale emergency department capacity and isolation room facilities in hospitals is also required. These actions would be best achieved through the establishment and resourcing of specialist networks operating regionally under a common governance structure. These networks should comprise relevant specialists and be linked to our extensive academic university infrastructure. This will enable rapid, scalable, regional responses to both current and future threats as they arrive and evolve, and enable rapid implementation of national guidance and adherence to national KPIs. I would like to finish by saying that, despite the optimism in some quarters in recent weeks, we are still in the midst of a national health emergency, and our citizens are no less at risk of severe illness and death if they contract COVID-19 infection now than they were back in March. Lessons learned from the first wave of COVID-19 need to be translated into actions and resources, but we have a very narrow window of opportunity. At a time when the incidence of COVID-19 infections in Ireland is relatively low, we need to avoid complacency and ensure that this time is used wisely to improve our infrastructure. Failure to learn or delays in the planning and resourcing for what is ahead would not only be potentially negligent, but would be a travesty to the memories of those who have died from COVID-19, some avoidably, during the first wave.
Thank you very much, Professor Mallon, and also thank you for keeping it within the 5 minutes. I'd now like to call upon Dr. Henry for your opening statement, please, and I'd also ask that you limit it to 5 minutes, please.
Good morning, Chairman and Members. Thank you for the invitation to meet with the Special Committee on COVID-19. I'm joined by my colleagues, Mr. Damien McCallion, National Director, Ms. Niamh O'Byrne, National Lead for Testing and Tracing, and Dr. Cillian de Gascon, Consultant Virologist and UCD NVRL Lab Director. Chairman and Members, as requested by the committee, we submitted last week a detailed document on testing and tracing for COVID-19. I will therefore, in this opening statement, make some summary comments. Since the onset of COVID-19 pandemic, the HSE has worked tirelessly to build a robust testing and tracing infrastructure with the aim to monitor and reduce the transmission rate of COVID-19 in order to protect public health. It is important to acknowledge the extent of what has been achieved as part of this response. To date, we have developed a testing system that has enabled us to complete over 400,000 tests. Our World in Data ranks Ireland 6th in the number of tests per head of population within the EU and UK. There will be many complexities to the testing infrastructure that have needed to be considered and overcome. Carrying out PCR testing for COVID-19 has proved challenging at times. The process involves more than simply taking swabs. There are multiple layers to the process that impact the end result. Firstly, we had to set up 48 test centres to take swabs, the first of which opened on the 16th of March. Within 10 days, more than 40 were open. We then had to consider how we would increase laboratory capacity to meet the expected demand. Thirdly, we had to ensure we could increase our ability to contact trace to a larger scale than had ever been performed in the country to date. We also built new IT systems to enable us to track and trace individual results through the process. To do all of this, we had to redeploy staff from other areas of the HSE and other public sector bodies, set up centres to support our public health departments, and build a system from scratch to enable the service to function. This had to be done while responding to the ongoing pandemic, something that has been described in initial responses as equivalent to building the plane while flying it. It has been well publicised that we had issues in testing in the early stages with delays in access to testing and the return of test results, much of this connected with global issues in the supply of test kits and reagents, our local lab capacity and a broad initial case definition. The case definition changed as knowledge of the virus and its characteristics increased. This required close work with the primary care community to respond to changes in the case definition and referring for testing accordingly. We have strived to overcome these challenges to build a more robust system capable of meeting demand today with flexibility into the future for any potential future surges. Despite early stage issues, we have strengthened our capability to protect the nation's response to COVID-19. Since May the 18th, we have the capacity to deliver 100,000 tests per week across our end-to-end testing infrastructure, from referral through to contact tracing. We've reduced our turnaround times significantly, with swabbing appointments mostly same day or next, laboratories completing testing in 1 day and contact tracing also completing in 1 day. In order to meet the need to trace contacts at a large scale, a contact management programme has been in operation since March. It operates a 3-call process to efficiently contact trace a confirmed case and also conducts active surveillance for 14 days from contact with a confirmed case. We are one of the few countries to offer automatic testing for contacts of a confirmed case. This has been in place since May. We are ensuring that we remain agile in our approach, driving continuous improvement and striving to be as proactive as possible in our response. Week on week, we make changes that increase efficiency. However, we still face some challenges, including anticipating the ongoing number of tests which will be carried out per week. Referrals from GPs have fallen recently in line with reduced disease prevalence, and positivity rates have fallen from a peak of 25% to 0.5%. As a result, the demand for our available capacity has been lower in recent weeks. However, we must keep in mind that as the country begins to open, we may see a demand for increased capacity once again, and we need to be ready. The current testing and tracing service was put in place in order to meet the immediate requirements of the Covid-19 crisis. The design of a new model that will operate for the next 18 or more months has commenced. This critical project will run over the summer months with a targeted implementation date in late August. It will focus on building a fit-for-purpose, sustainable testing service that will deliver short turnaround times, maintain long-term capacity, effective contact tracing, and be flexible for any future surges that may come. Finally, I would like to sincerely thank everyone who has played a part in developing the current testing and tracing operational model, which has enabled us to protect public health to date. We are most grateful for the support of the GP community who have worked with us since the outset in a very collegiate, practical and productive way. Testing and tracing, along with other public measures such as social distancing and good hand hygiene, will play a big part in all our lives until a vaccine for Covid-19 has been developed and delivered. This concludes my statement, and we will be happy to address any questions you may have. Thank you.
Thank you very much, Dr. Henry. I would now like to open the floor to members. The first speaker is from Fine Gael, Deputy Burke. Are you taking 5 or 10 minutes? 10 minutes, go ahead.
Thank you very much for your presentation here this morning, and indeed for all of your work over the last 3 to 4 months. It has been quite a difficult time for everyone involved, and I think there was strong leadership provided by the people in the medical advice given and in delivering. Can I go back to Dr. Henry and just discuss just very briefly in relation to a lot of the facilities for testing, etc., are now being wound down, and some of them have ceased to operate. If there was a surge again in the morning, what kind of time period would it take to have everything up in full working, being able to provide tests fast again if there was a sudden surge?
Thank you, Deputy. The number of testing centres we had at one stage was 48, but clearly based on the reduced demand per week, we built up a capability for 100 tests per week. But now we're seeing, with falling community transmission, the demand for testing reduce week on week to now 18,000 tests in the last week. We have testing capacity for upwards of 100,000 per week. In terms of contact tracing, we similarly set up a contact tracing exercise to support our public health departments in 10 departments around the country. These are mostly consisted of both medical and non-medical staff who are supporting and doing the more routine contact tracing exercise. Again, the demand of that has fallen considerably with reduced community transmission and reduced numbers of contacts per case from a peak of 20 in mid-April to about 3 or so now. So we have the capability we've centralised the contact management programme. I'd asked my colleague Niamh Byrne to come in on this into a unit in Galway, but we've retained the capability to ramp up considerably at short notice should we see an increase in the R value with an increased number of positive tests with contacts. I might ask Mrs Byrne to come in.
Yes, Deputy, thank you for the question. In contact tracing, we have consolidated to one centre in Galway with the capacity to do 150 tests, of positive tests. So what we've agreed with all the centres that did work with us, that if we have 3 days of 100 tests consecutively, we will step up the other centres again. We do remain having 1,700 people trained in contact tracing, and everyone who did work with us is committed to come back in that time frame.
And just on the contact tracing, where someone has been identified positive and you're doing the contact tracing, are all the people that they have been in contact with then provided with a test as well?
Yes, since over the last number of weeks we've been doing automatic testing of the contacts of confirmed cases on day 0 and day 7. So everybody is offered a test and it's scheduled for them, and then they're told to self-isolate for 14 days and they test a second time again within their 14-day incubation.
And what kind of numbers are we talking about of people who were contacted as a result of a person identifying positive and had to test?
2,600.
People who were contacted?
Who have been contacted and tests arranged for.
And what kind of numbers of those 2,600 were then identified as positive as well?
I'll come back to you with exactly the number, but the positivity rate is around about 10%.
Okay, thank you. Can I just go on to this issue in relation to people coming in from abroad? What's your own view, Dr. Henry, in relation to people coming in from abroad? And we've now, the number of people being identified positive has greatly reduced, and we've suppressed the virus. But if we open up and people are travelling in from abroad, for instance, I understand in the UK there's quite a large number still being identified positive every day. What is your own view as regards the best way of managing this if there is a full resumption of people travelling from the UK or travelling from Europe or travelling from outside of Europe? What's your own view about the best way of managing that now?
Well, I'm a member of NEFIT Deputy, and there's considerable discussion of this and other matters at NEFIT. What I would say, Deputy, is, referring back to Dr. Mallon's opening statement, is it's far too soon for us to certainly to forget how transmissible this virus is. The events in Melbourne, Houston, in Germany and in several US states remind us that this virus can, with poor social measures, with rapid easing of social restrictions, we will see rapid return to community transmission of this virus on a scale which is hard to deal with if it's not under control very quickly. So clearly there would be concerns for people coming from areas of high impact, particularly, but in the COVID environment, unfortunately, we have to treat every potential person as being potentially positive, given the uncertainty that pertains right across Europe.
But if someone is coming in from the UK, they're advised to self-isolate for 14 days. What do you think adequate measures are in place to make sure that that's followed through on?
Well, the advice is given to people, and the hope is that people will comply with such advice. It's up to individuals to, as they have done since March the 27th in this country, to comply with the advice and the guidance that's given in order to break the chain of transmission. So that's the advice for people coming in from the UK.
But the question I'm asking you, do you think there's adequate measures in place to make sure that that advice is complied with? At this,
we haven't a system in place where we track and trace every single individual who comes into our country for 14 days. We depend on, what we do give very stringent advice to people that this is what we consider appropriate in the context of the transmissibility of COVID-19 and the potential of somebody coming into our country transmitting that virus unknown to them. So we don't track and trace ourselves people who come into the country at this stage.
Can I go back to something that was presented to us here at the committee on Tuesday, and that's by the INMO, where they advised that, as we were all aware, that over 8,000 healthcare people working in the healthcare area were identified positive. And we're now advised that over 60% are still out on sick leave. Have you, do you think that represents a true and accurate figure in relation to numbers out who are still affected as a result of being identified positive?
Deputy, the figures I have from our own HPSC is that 90% thankfully have recovered. Clearly, that any of our healthcare workers in the front line, be it in the community, in nursing homes or in hospitals, are a concern to us, given that they're delivering care for patients, sometimes very personal care in the case of older, frail residents. And it's hugely important to us, as well as as important to us as well as to the INMO, that we can provide a safe working environment for our healthcare workers.
Oh, you disagree with the figures furnished to us on Tuesday? You were saying it's 90% have recovered.
Our figures from the HPSC are that 90% of the total number of patients, of healthcare workers who have Covid-19, which comprise 32% of our total overall figure, that 90% have recovered.
And is it possible to identify, of the 8,180, I think, as regards, are figures available as regards where those, how is that figure made up from what facilities? Is it nursing homes, hospitals? Have we a full breakdown? And is it possible then to identify where the 90% have recovered? Because the figures given to us on Tuesday were totally different from what you're giving to us.
We have a breakdown based on the healthcare setting, Deputy, and also based on profession. And in terms of those associated with outbreaks, and we can provide figures to you after this hearing.
Okay, I appreciate that. And finally, can I just ask, in relation to the rollout of a cervical check is going to resume, and as regards the amount of work in that, involved in that, at what stage do you believe that we can go back to having the full comprehensive service in relation to providing the type of service that we require in relation to cervical check? How long will it take to have that up fully working and in operation?
Deputy, as with any other service we're resuming that was paused in March of 27 as part of the wider package of pausing non-essential services, there are two assumptions that are important for all of us to consider here. This is an important, a valued and valuable service to us and to women in Ireland, and I would like to acknowledge the work with advocacy groups and the 221 group and others in terms of ensuring that we focus on restoring our services. What I would say is there's two major assumptions. One is that the community transmission level remains low, and the second is that there's continued easing of social restrictions. If we see a scenario play out as we've seen in other countries and some US states with a sudden rapid community transmission, clearly it will give us reason to pause resumption of services, be it screening or otherwise. But to answer your question directly, our hope is that notwithstanding those assumptions, that we will have caught up, if you like, with all those who would have had cancelled appointments through this whole pandemic since March the 27th by October. I would add, Deputy, very briefly, that one of the positive aspects of cervical screening is that we're now moving to HPV screening, a more sensitive form of screening, and one which is...
Very much, Dr. Henry. We'll have an upcoming session on screening, among other sort of non-COVID related activities, as we'll also have another session on infection rates of healthcare workers. Just Dr. Mallon, on the issue of travel, do you have a view on the adequacy of the measures, whether there's confusion or not between legally requiring people to fill in a form and then requesting that they quarantine, etc., all those issues?
I guess I would have two views. When you look at what countries that Ireland is in the position of around the world have done with resurgence of cases, the majority of the resurgence is actually occurring because new infections are being introduced to the country, either through people travelling into the country or through perhaps the movement of some goods. So from that perspective, the importance of containing infections at your borders becomes higher as your levels of community transmission drop off, because it becomes in effect your greatest threat of resurgence of cases. So from the policymaker perspective, if you want to maintain community transmission at a level that is minimum, and you're working on a series of complex interventions to maintain that, it's important that you have a robust screening methods at the point of entry into the country. What they are, I think, would be open for debate, because certainly you could screen everyone, or as is being proposed, which might make more sense, is that you judge your screening and you judge your restrictions and follow up based on the epidemiology of the outbreak in the country where the person's coming from. So, for example, someone coming from New Zealand at the moment compared to someone coming from Texas, the risk assessments would be very different. And I know that that might be a pragmatic approach, certainly within the European setting, to enable limited travel, but at the same time focus your testing, follow-up restrictions and monitoring of that, where you'll get the most return for your investment of time and expense.
You didn't answer the adequacy of existing measures.
The adequacy of existing measures, I think it would be useful to know to what extent the new cases that have been reported in the last couple of weeks have arisen because of inward travel, and that's really what we don't have. And to be able to comment on the adequacy of existing measures, you'd need to know to what extent the travel is a component of our existing onward transmissions.
Thank you. Fianna Fáil, is that Deputy Donnelly for 10 minutes? Off you go.
Thank you, Chair. Can I thank our witnesses for their preparation and time this morning? It's much appreciated. And Chair, I'd just like to acknowledge the great work that the committee secretariat has been doing. The briefing notes have been excellent. I just want to put that on the record too. Professor Mallon, could I start with you? You say in your opening statement, the infectious control community believe that it is inevitable we will experience a resurgence of cases as we relax restrictions and permit more travel. Can I ask, in your view and the view of the infectious control community, how extensive is that resurgence likely to be? And critically, could it lead to more mass closures of healthcare facilities, of businesses, of schools and so forth?
Thank you, Deputy. I think that if you want to get an idea of the extent of re-emergence, the best thing to do is to look at international examples just from the last couple of weeks in countries that have low levels of community transmission. So, for example, in Germany, we've seen a large outbreak associated with one particular occupational factory that's led to the lockdown of, I think, 600,000 people. In the state of Victoria at the moment, they're really grappling with re-emergence of cases within multiple hotspots within the community that has led to severe restrictions throughout a lot of the state. Over 1 million people are currently under almost don't leave home restrictions. So this can emerge very quickly. When you look at the example of Victoria, this has emerged in a matter of days, that they've gone from a country that had been largely COVID-free to having to introduce quite severe restrictions to a large segment of an urban population. And when you look between the lines at Victoria, one of the other lessons to learn is that they're actually scrambling at the minute to try and upscale their testing capacity. And I think that that's a lesson that we also need to learn. We can't get rid of all of our testing capacity and expect to switch it on overnight. And your ability to be able to respond to these sorts of outbreaks, you've got days, you don't have weeks.
So can I ask, given all of that, in your expert view, given what you're looking at around the world, given Ireland's current state of preparedness and the capacity we have, is there a reasonable likelihood that we could see mass lockdowns again this calendar year?
The likelihood of the lockdowns really depends on two factors. I think the first stress test for the system is going to be what happens in August as the Irish people decide whether they travel overseas or not, because we will inevitably have imported cases coming back into the country. That is going to stress the testing system. The second big stress for the testing system is going to be the onset of seasonal influenza, because you're going to be getting a large number of people with symptoms consistent with COVID seeking tests at one time, and we need to be responsive to that. Within those two settings, the likelihood of re-emergence of infections is high. The likelihood of reimposing restrictions really depends on two factors. It depends on the geographical spread of the infections. So, for example, if they're all localized in one geographical setting, you could argue for a geographical restriction. And it also depends on the number of cases and the rate of increase in those cases.
And can I ask you, you're giving a very good academic and medical answer. Yeah. You're giving me all the criteria. What I'm asking you is, given all of those criteria, in your expert view, is it likely that we will see another lockdown, mass lockdown?
I think it's inevitable that we will see restrictions being brought in. When you talk about mass lockdown, the inevitability of a mass lockdown depends on what happens with the new cases. You could argue that within Ireland, if we set up the testing and contact tracing system appropriately, you could place restrictions locally, as they're doing in the state of Victoria and as they're doing in Germany. But if you get a large number of people returning to the country from overseas and you've got wide geographical spread of community transmission and you can't test and contact trace efficiently, the only way that you're going to control that is by returning to mass lockdown.
Thank you. Can I ask as well, Professor, you say in your opening statement, infectious disease physicians have called for a written, detailed, coherent plan dealing with the control of COVID-19 on the island of Ireland. This should include a detailed end-to-end testing and tracing plan. Can I take it from that you were saying there is not currently a detailed end-to-end testing and tracing plan, and that we do not currently have a detailed, coherent plan dealing with the control of COVID-19 on the island of Ireland?
That would be the view of the infectious diseases physicians in the country.
Okay, thank you for that. Can I ask, in terms of how we might deal with another future outbreak, because obviously we have to do everything we can to avoid future mass lockdowns, are the advances in home testing, in mass testing way beyond the current capacity we have now, in antibody testing, etc., are the advances in those technologies such that you think it likely that this calendar year those technologies could be deployed en masse to help with a much broader test, trace and isolate regime?
Simple answer is no.
Okay, thank you. With regard to measures around international travel, where is the technology in terms of being able to test people at the airports, specifically in terms of the turnaround times? My understanding is the very rapid testing, the 15-minute testing, is not advanced enough right now. But if we were to put labs in the airports, in the ports, could we do testing and have passengers wait for 1 hour, 2 hours, 3 hours, for example, instead of having to potentially self-isolate for 2 weeks?
So there is availability of a rapid test, which is a nucleic acid-based test, which is the gold standard, that will give you a turnaround time of between 40 minutes and 1 hour. You will not, for the foreseeable future, get access to enough of those kits to make it feasible to place at the point of entry for airports.
So given whatever technology is available, if we were to put labs at the points of entry, how long would passengers have to wait to get a test result?
I would estimate your quickest turnaround time would be 3 to 4 hours with batch testing, PCR-based assays. The other caveat with that is that will identify, in much the same way as has previously been mentioned, it'll identify your day zero positivity rate, which at the minute for contacts is 10%. It doesn't predict if that person is going to develop symptoms or not. So its utility is it's useful for that day to remove people that are infectious, but it doesn't solve the problem of ensuring that you follow up those people that are coming from high-risk areas to ensure that they don't subsequently develop infections over the coming days, because that will still transmit and cause infections in the country.
So, for example, if we were to have a regime that tested at the airport and you could wait your 3 hours to get your test and then had a follow-up test 3 days later, would that be an equal level of biosecurity to asking someone to self-isolate for 2 weeks?
I think that it would, every time you test, you improve. Now, what the testing does, because it's not predictive, what you're doing is you're removing positive cases from the pool. So with every test that you do, you remove more positive cases. And you could test every day for 7 days, and it would be better than testing at day 1 and day 3. It's never going to be 100%. And along with any plan for testing, you're still going to have a requirement for the individual to behave responsibly,
sure,
report symptoms, and in my view, given the impact from a public health perspective of community transmission of this virus, as has been demonstrated in Victoria, and the economic impact of it, it's hard to see how quarantining for 14 days, how something would improve that.
Sure. Can I ask you, you stated in answer to one of my previous questions that we need to have a very robust test, trace and isolate system in place to avoid future mass lockdowns. In your opinion, is the regime currently robust enough to deal with that?
The regime needs to be 24-hour turnaround time to be ideal, and I think that that's feasible. It's feasible.
Sorry, just in the interest of time, I understand that, but I'm just asking right now where we're at. Are we there yet?
Within hospitals, the majority of hospitals were there. The majority of hospitals' turnaround time is within 4 to 5 hours, no more than 12 hours. All tests are back within 24 hours. In the community, that's where it needs to be. And I'm not quite clear with these different testing tracks what the average turnaround time is, or what proportion of community testing
Thank you.
is
I
actually
just want to get one more
hours.
question in. Apologies for cutting across you. The INMO and others have called for temperature checking, daily temperature checking for healthcare professionals coming into hospitals. Other countries deploy it for workers going into office blocks. And my understanding is even for bars and restaurants, very advanced regimes like South Korea, Taiwan and others do that. Do you believe that that should become one of the tools in our arsenal for containing or ideally eliminating this virus in Ireland?
In terms of, again, a complex interaction for the reduced transmission, it's useful. But it needs to be part of a package of measures, and to introduce temperatures alone and think that you're going to solve the problem, I think will be naive. What you need is a complex series of interventions which will include surveillance. As part of that package, would you be in favour of us bringing it in? Anything that reduces the impact of COVID-19 within our hospitals will be useful. And you think this would help with that? It would definitely help. Thank you. Thanks, Chair.
You mentioned the shortcoming of the PCR type testing, and you said there was another type testing which you said wasn't available because of logistics. Does that suffer from the same disadvantages, i.e. that, you know, if you're tested in your first day or two after contact, you may subsequently develop symptoms, but you won't test positive? That's true. So it still suffers from the same limitation of it being a point-in-time test. It'll tell you if you're positive at that point in time. It doesn't tell you if you will develop the infection if you've been exposed. Even the first type of testing which you mentioned? Yes, yeah, both tests. Thank you very much. Thanks. Deputy O'Reilly, you're taking 10 minutes?
Yeah.
Thanks.
Thanks, Chair. Thanks to our witnesses, and thanks for the information that you've given us this morning. My first question is for Dr. Henry, and Dr. Henry, we are very, very constrained on time, so a lot of the answers I'm looking for are either one word or one number, if you don't mind. So look, we know that the experts are telling us that testing and tracing doesn't necessarily have to be perfect under lockdown, so fair play, but it does need to get much better, and it should be perfect as we exit. So are you confident that we will be able to hit the necessary end-to-end targets from the first call to the GP to quarantining contacts? And, you know, that the target is 72 hours. I'm not sure that we're there yet or anywhere close to there. I have a PQ response from the HSE that tells me that the turnaround time from the test, the request of a test, and the start of the contact tracing process is 1.76 days. That was as of the 19th of June. So would you be confident that as we exit lockdown and there's more pressure on testing and tracing, that we're going to be able to hit that 72-hour target?
In short, yes, Deputy, we're around 90% within 72 hours, but the median, I'll ask Niamh O'Byrne very briefly to give you the median times from the past week, so I know you're under time constraints, so very quickly.
Yeah, 1.7 days is the median for end-to-end. That's from the point of referral to the end of contact tracing. It's 2.1 in the community and 1.54 in the acute sector.
So it's 2.1 in the community. Now, does that include the instruction to all contacts to quarantine, or does that include a test for all contacts?
That includes, that's the moment where we contact the contacts, let them know that their test is to be scheduled.
And that's for 100% of them, that 1.76?
That's the median number.
That's the median number. Okay, but that's, so is that's not being hit in the community though? It's much higher than that in the community, am I right? 2.1, 2.2? No,
that is, the number is 2.1 in the community. That's
2.1 in the community, okay. So that's 2 days. So we're still a wee bit off there. Just with regard to the 100,000 tests per day, per week, sorry, have you ever hit that target?
No, in short, no. And it was based on we built up a capacity for 100,000, but based on reduced community transmission, it's now dropped the number of tests between those who have conformed to the case definition and other testing strategies we have, be it nursing homes or healthcare workers, has now fallen to below 20,000.
Okay, but would you be confident that you'd be able to scale up to hit that target?
In short, yes.
I'm not being funny now, but what are you basing that on if you've never done it?
We developed the capacity to do it, Deputy, and we haven't had to use it yet, which is fortunate for all our sakes. But the capacity remains in terms of the purchased lab capacity. If you want to ask further, Damien McCallion is here, I can brief you on that, and also based on the testing centres. So right through that pathway, we built up a potential capacity of 100,000 tests per week. The fact that we haven't had to use it doesn't mean the capacity doesn't exist.
I think we're all grateful that we haven't had to use it. Professor Mallon refers to the need for a detailed end-to-end testing and contact tracing plan with rapid turnaround times and key performance indicators. That's not there. Is that on its way? When will we have that?
Yeah, in short, yes, Deputy, and as my colleague Eva Byrne described earlier, we expect to have that by August.
By August, yes. So we produced a plan by the end of April, which is a plan we've delivered to reach our capacity by the 18th of March on our 90% turnaround in 3 days. So we are working to a current plan. What we're doing now is building a long-term sustainable model for the coming years, and that's to be in place by August, and that will have a new organisation, set of technology, a new set of KPIs, business case and process. So that's what we're building at the moment to make a sustainable model, assuming that the disease will be with us for the coming years.
Okay, Professor Mallon, experts are telling us that testing capacity alone can be a bit meaningless unless it's fast. South Korea have used the speed of testing and tracing to prevent and suppress outbreaks. Their health officials have stated that testing needs to work for isolation, not just for identification, and to do that it has to be fast. Dr. Tomas Ryan tells us that the science shows us that if we're too slow, it will defeat the purpose of having a lockdown at all. Professor Mallon, you make this point in your opening statement where you indicate that as society reopens, the public is handing back some of the responsibility for controlling the virus to the state, and if the programme of testing fails to work effectively, we will risk losing the gains provided. Can you outline what you see as the necessary underpinnings of any successful testing and tracing plan as we exit lockdown?
Any successful testing and tracing plan needs to have the capability of responding, at the very least, to the new onset of a flu season, where rates of people with flu-type symptoms increases exponentially over a very short period of time. Now, you can model that when you look at our last flu season, which just preceded the onset of the Covid-19 pandemic. You can estimate that we had about 103 of every 100,000 people per week were reporting flu-type symptoms to their local GPs. That would correspond to an expected need for diagnosis of positive cases of over 5,000 per week. So you need to be able to go from diagnosing at the moment probably about 100 cases per week to potentially dealing with people with symptoms in excess of 5,000 per week or maybe higher. Take into that and account that if people slip through the gaps with Covid-19 because of either delays in testing at that higher capacity, not only will you be faced with flu-like illness, but you'll be faced with Covid outbreaks. That will increase the capacity yet again. That's what you need to be ready for, but you need to be ready to roll that out within days. And
can I just ask, do you think we are ready? Do you think we are ready?
It hasn't been tested, but certainly when you look at, for example, the closure of a lot of our testing hubs, the fact that we still don't have a clear written plan about how we're going to upscale those testing hubs, the multiple need in the steps in the document that I provided of the referral pathways, reporting pathways, all of these are critical and need to be looked at to get the timing done. And at the moment, I don't think the time is good enough at a low rate of community transmission with a turnaround time of 2 days. With a low rate of community transmission, we should be at 1 day.
1 day, yeah. But if we don't have the necessary plan in place, should we be opening up at the rate that we're opening up? Should we not wait for the plan? And I'm asking for, I have my own view, but I'm asking for your view as an expert in this area.
I believe that the opening up that's happening at the moment is being undertaken generally responsibly because we have good data on community transmission, and provided that we can watch community transmission, then we can see the impact of the relaxation of restrictions. I had a lot of concerns that we were doing it too quickly, but those concerns have not played out into increased rates of community transmission. I'll still be concerned. I think that is, especially as we move into the next phase, because the next phase where you get much more movement of people, that's going to be a real test. So at every stage, I think we need to watch, but as long as we're able to accurately observe those community transmission rates, we get the information we need to know if we're going too fast or too slow.
And if we open up our airports and we open up to travel, is that going to, that's obviously going to increase the risks? Would we need to be scaling up on a much quicker basis if we are going to be accepting people from, you know, as tourism restarts and everything else?
I think as tourism restarts, if there's no consideration for where the tourists are coming from, we're really giving ourselves a rod to break our back. I think that you will have dissemination of tourists from a number of different countries around the island. How we cope with that, how we monitor it. The big consideration is that the Irish people are on the ball with this. They've been engaged with this from the beginning. People coming in from other countries won't be in the same mindset. They may not have the same knowledge in terms of reporting symptoms, the same knowledge in terms of how to get tested. So the whole system around that monitoring, contact tracing is by definition going to be less robust for tourists, and that needs to be taken into consideration. It will increase the risk.
It will, and at the moment we have very, very low numbers at Dublin Airport in my constituency, so I know we have very, very low numbers arriving in through the airports, but that's likely to increase. But even at this rate, very, very low numbers. Was listening to the radio not last weekend, the weekend before, and Coach O'Riordan says she came home from America and she self-isolated, quarantined. She got no phone call. Nobody phoned her. Nobody checked where she was. So if we can't manage to do that for the tiny, tiny, tiny numbers that are coming in, what's our prospects of being able to manage it if we get back to even 50% of passengers arriving here in the next couple of weeks?
I think it'll be a test for our contact tracing, the contact tracing platforms that have been put in place, but I think that is the major concern. And I think that if we just completely open up our airports to all comers, I think that the risk, in my view, would be a risk that's not worth taking because of the potential consequences of widespread geographical community spread of this COVID-19 unwittingly by people coming into the country.
Thank you.
Thank you. You have repeatedly discussed the need for a written, coherent plan on this island, were your words. Are we any closer to that in this jurisdiction than in Northern Ireland, or is there a similar? Are we at a similar distance?
I think that. Thanks for the question, Deputy. I think one of the most frustrating things about this pandemic has been that comparison of what we're doing versus other countries, and I think that it's very clear to me from a pandemic scenario. We are unique. Our country is unique. We've got a unique healthcare capacity, which is lower. We've got a unique community engagement. So the characteristics of how we manage this pandemic, we need to focus on what we need within our country. Now, we can take lessons from other countries, but I don't think that we're going to be able to pull off the shelf a written end-to-end testing policy, contact tracing policy, and say, you know, the UK have done it, therefore we're going to do it. I just don't think it's going to work.
Yeah, but we continually talk about people coming in at an airport when there are a very sizable number of people coming in across a land border, which is inevitable. And
it's something that I've brought up repeatedly. One of the approaches that we haven't taken, that other countries around Europe have taken, is we haven't taken until recently a very strict approach at our borders. You know, we've got a large landmass border with the United Kingdom. That we have no restrictions over. So even if you put restrictions at the airport, you can still get people travelling across that land border. And I recognise the limitations with that. But I think that when you look at other countries around Europe with large land borders, they've been much more restrictive in terms of movement across those borders than we have.
Thank you. Deputy Smith of the Green Party.
Thank you very much. I'd like to start by asking about the cost per test. Now, I know when you're thinking about cost, there's marginal cost, and then there's kind of your fixed capital, and you've got your recruitment and everything. But in general, usually labs have an idea of how much each test costs. So just in simple terms, can you give me a number for that?
Thank you, Deputy. I'll ask Mallon to answer.
Deputy, so I suppose in terms, there's a wide range of costs. I suppose I'll break them into two ranges quickly. The marginal cost in terms of hospital cost broadly averages out at around €75 per test, but there's a significant variation between the hospitals and between the testing platforms that are used. So it's quite a variation there. We're being very careful in terms of the commercial rates because we're still negotiating with laboratories and Sintron to build further capacity going forward. But broadly speaking, they range from €140 down, and at the moment we have rates that are well below that. So average rates, the budgeted rate is typically around €120 per test, and we're operating below those levels at the moment.
Okay. I'd like to ask about the PCR equipment that was acquired. Presumably large additional quantities of PCR equipment was acquired and also staffed up as well. Will that serve us? Is that adaptable to other diseases that may come along? Are they sort of generic machines that can be used for different types of reagent if another pandemic comes along, or for testing, for example, for influenza?
I'll ask Dr. Killian the Gascon, Deputy, to answer that question.
Thanks, Deputy. And this was in the context of time. The short answer is yes. Most of these platforms would be usable for things like influenza, as you've alluded to, or for sexual health, or for bloodborne viruses like HIV, hepatitis B, hepatitis C. The PCR is not a very, I suppose it's quite an agnostic technology which you can use for a variety of infectious pathogens.
Okay, and to get staff skilled up to use these PCR machines, what kind of staff do we need for that? Is that PhD level, or could you retrain clerical staff if needed?
Ideally, you're looking for somebody with a science background. Most of our staff would be either technical officers or medical laboratory scientists. There is certainly a shortage in medical laboratory scientists across the country at the moment, but from the point of view of training people up to operate these machines, they're very capable, and many of them would have transitioned from existing work to work on COVID-19 testing. As you'll be aware, a lot of the demand in the health service declined significantly due to COVID-19, so we saw the same issues in the laboratory. So basically people were transferred from operating, as I said, perhaps in areas of, say, sexual health screening or something like that, and came across to work on COVID-19. But I think we do need to invest in medical laboratory scientists. I think that's well recognised.
I want to ask about testing at airports. One of my relatives is an Irish citizen who arrived in Hong Kong airport recently, was tested on the spot, kept in the airport for 5 hours until the results came back. So it was a 5-hour turnaround, and then confined to their home with a tracking device for a period of time afterwards. Are we going to test people arriving at airports? I mean, it seems that if we can completely suppress the illness within our island, if we allow continued, if we reopen our transport to other countries, we are presumably exposing ourselves to huge risk there.
Bearing in mind the concerns of Professor Mallon and others, as we reopen our airports and allow increased travel, clearly anything that reduces the risk of transmission, particularly from people who may not, as Professor Mallon pointed out, it's a point-in-time testing, so anything that allows reduction of risk by releasing people who have positive results, whether asymptomatic or not, it will clearly have to be considered. It's not something we're doing at the moment. It's under active discussion at NEFIT, and we'll doubtless inform our own testing policy. So it's not something we're doing at the moment, but anything that would reduce dissemination of the virus should be seriously considered by us. Okay,
so it's under consideration, and I just want to point out that it is actually happening in other countries, so that there is an international precedent for that, even if we don't go that far. In terms of antibody tests and serology tests, obviously the science in this is advancing all the time. Is there any idea yet that there's any point to doing? I see that you can go to a private serology testing clinic in Dublin. There are a number offering this test. Do we have any idea how long immunity lasts, if at all, if you have the antibodies? And is there any plan to kind of do some scientific research to see the extent of the antibodies in the Irish population?
Thanks, Deputy. So last week we began the SCOPI seroprevalence study, which is intended to look at the proportion of people in the population, the Irish population, that would have been infected with SARS-CoV-2. At this stage, the plan is to call forward or invite just over 5,000 individuals who will be representative of the population at large, and offer those individuals a blood test to look at the level of antibodies in their blood. At this point in time, we don't have an indication as to how long immunity will last to SARS-CoV-2 if antibody is present in an individual's blood sample. Based on previous coronaviruses like SARS and MERS, it's possible that immunity will last for 1 to 2 years, but at this point in time it's too early to say that. My understanding, and excuse me, Professor Mallon might want to come in on this, that there is a significant amount of research ongoing in the area of antibody testing.
Mallon, did you want to come in?
Yes, so just in terms of the national research piece, we have a cohort study called the All Ireland Infectious Diseases Cohort Study that's running in 12 centres around the country currently, recruiting patients both with and without COVID-19. We've just put through 1,000 samples from patients 3 antibody tests, and we're waiting the results of those. We expect those within the next day or two. Just in terms of what we know, though, what's emerging is that if you have a mild infection, chances of having antibodies are lower, the level of antibodies are lower, and the chances of those antibodies hanging around are lower. So it seems to be that those that are more severely infected may have higher antibody levels. How that corresponds into any protection from future infections, we really don't know.
Okay. I want to thank the witnesses for answering my questions. Thank you, Chair.
Thank you, Deputy Smith. Deputy Gannon.
I found it to be a fascinating session. It's also quite frightening in the sense that it's left me in no doubt that we probably should respect the resurgency. And I want to ask about if the second wave should happen. In regards to testing and tracing, what would we do differently? What lessons have we learned from the past couple of months? And if there's a second wave that's significant, what would we do differently in relation to testing and tracing?
Well, clearly, Deputy, thank you. I might hand over to one of my colleagues in a second, but to answer your question as quickly as I can, the lessons we learned clearly from having to respond very quickly the first time was our capacity was the first thing, that having a capacity to deal with the number of potential positive cases, suspect cases, and targeted strategies among healthcare workers or nursing homes or otherwise. And so that clearly was a big lesson for us. The second, and again echoing what Professor Mallon says and others, is the turnaround time, the response, which is now reducing all the time. In mid-April, when we had significant problems with each step of the testing pathway through shortages of swabs or shortages of reagent, we had to compete in a very, very tight competitive international market for some of these, to secure the swabs and reagents to allow the pathway to continue. So those contracts, thanks to my colleagues in the HSE, or some of who are here today, we've secured those different things which enable each step of the pathway. So that the turnaround time is in the community is the second thing. In the hospitals, it's already at a 1 day in most hospitals because of the nature of the patient being there. So the second lesson, if you like, for a second surge, whenever it comes and whatever form it takes, is how quickly we respond to cases, how much we increase awareness among the public of the importance of presenting early with symptoms, and of how doggedly we pursue close contacts of each known case to test them also.
Thank you. In relation to reagent, just to confirm, we do have enough reagent now at this moment, should there be a second surge?
I'll ask Mr. Callion.
Yeah, just briefly, I suppose, Deputy, I mean, this is a constant challenge at the moment. We have a secure supply and we're comfortable with what we have beyond even the levels of testing that are there today. But if a number of countries got a resurgence at the same time in a global sense, there would still be challenges there. What I would say is that the market has obviously invested a lot in manufacturing to increase that. And we've also looked at things like, and Dr. Gaskin may wish to speak on this briefly as well, diversification across platforms. So we're not completely dependent on one or two platforms, which could present problems then if such a situation arose globally.
Thanks, Deputy. Just to echo what Mr. McCallan has said, I suppose one of the things we did learn at the time is that ourselves in the National Virus Reference Laboratory and a number of the hospitals around the country, the hospital laboratories were pulling from the same global supply chain because one of the platforms was particularly good from an extraction perspective. So I think what we've done with the help of HSE procurement over the recent months is ensuring now that we've diversified across the hospital laboratory network, so hopefully we won't get caught in the same situation again.
Thank you. I want to ask about the strategies in care homes at the minute. How much ongoing testing of patients and healthcare professionals in care homes is happening at the minute?
Deputy, two things. First of all, we did a blanket exercise right across care homes, residential settings, disability settings and mental health settings in April, which gave us limited information given that there was relatively low levels of positivity, although there was geographical variation. We are now this week starting on a series on testing of all healthcare workers in nursing homes for 4 consecutive weeks to help inform us more of the behaviour of this virus among healthcare workers, and in view of the fact that we can't always be certain where it was contracted, to give us more information as to how the virus was contracted and the behaviour of it among healthcare workers. My colleague Niamh O'Byrne may want to comment on that.
Yes, Deputy, we commenced yesterday a serial testing for the next 4 weeks of all healthcare workers, which we estimate to be around 33,000 people across 586 nursing home settings. And we're going to do that for 4 weeks. We'll produce a report at the end of every week and then at the end of the entire exercise to see what we've learned from it and how it informs our testing strategy for healthcare workers in those settings going forward.
Thank you. So how are you using your existing capacity considering the somewhat low demand at the minute? So are you doing asymptomatic testing in high-risk settings such as meat factories, for example?
The testing is used in a couple of ways, Deputy. One is people who conform to the case definition, which now, because community transmission has fallen so much, has fallen to very low levels in terms of demand. Secondly, to support specific strategies guided by public health. So that could be in the context of outbreaks, which again have fallen because of the fallen rates of community transmission. And thirdly, specific strategies to inform us, be it among the behaviour of the virus among healthcare workers in nursing homes, or to inform a strategy we've just developed and passed through NEFIT, which is a broader strategy of how we use our testing capacity to test healthcare workers in different settings to inform us about, again, as I said earlier, how it behaves among this population and how it's transmitted among this population. So we have, as I mentioned earlier, much capacity at the moment, much of it unused, thankfully, but we need that capacity for any surges, which, as Professor Mallon says, appear more likely than not in the coming autumn-winter season.
Thank you.
Thanks, Deputy Gannon. Deputy Barrett.
There's not as many people here. Will we get a chance for a second round? Because now that we have our experts...
Well, if we do get a chance for a second round, everybody will have equal opportunity to come in, but just because there aren't as many here, I mean, there are other people who are coming and going. I mean, like yourself, who've just come in, you'll ask your questions.
I've been watching the whole thing, but for public health guy...
You, like others, are following it from...
Precaution, I was watching.
From offices.
Yeah.
But do you want to take the first round first?
Yeah, I'm just asking, will we get a second chance?
No, if there's time left over, of course.
Right. Okay, first of all, I just want to formally put it on the record, my request that the minutes of the expert advisory group would be published up to date, okay? Because I've asked now, I don't know how many times, it's just boring how many times I've had to ask. And it's even more important that these are published, that we know what the experts are saying when there's very significant pressure from industry to lift restrictions. We've heard some of the dangers of the lifting restrictions could bring about, and we don't know what. Well, there's a 5-week lapse in the information available to us about what the experts, which I'm currently limited to 5 minutes to ask you questions. It's just preposterous, frankly. So that's a formal request that we have the minutes of the expert advisory group published as soon as they are signed off on and put up on the website.
Do you want to put that to Dr. Gascoigne or just put it on the record?
Well, it'd be great if we could get an answer, if there's any difficulty with that.
He's in Committee Room 1 if you want to ask.
Yeah. Just yes or no would be great.
Dr. Gascoigne?
Thanks, Deputy. I received correspondence from the committee after my last appearance, and the minutes and advices up to the middle of May were sent through yesterday evening. I will take on board Deputy Boyd Barrett's comments. I suppose we're conscious of not having matters in the public arena that are undergoing active consideration, either ourselves or NEFIT, because I think that could impinge on the work of the committees. But certainly we're working to get things out as quickly as possible in conjunction with NEFIT. We are a subgroup to NEFIT after all.
Okay, well, I just want to say, again for the record, that is, I mean, we can debate the extent to which the public should or shouldn't know what your deliberations are, right? But as people who are responsible for oversight of this effort and on this committee, I think we should know what the debates are. Right, and I was reading your latest minutes, for example, on the debate about masks. I haven't got time to go into it, but it's a very interesting debate that's going on at your group. But it's 5 weeks ago. But we're having to make decisions now. So I'd like to know the most up-to-date advice on masks and face coverings and the debates that are happening within the expert advisory group. That's one. So I just, hopefully that can be taken on board. Could we have more information about who's getting the infection? We're told there's community transmission. I know it's low at the moment, but surely we need to know. Maybe you guys know, or maybe you don't know. But I'd like to know, do you know? And if not, why not? who's actually getting infections now? And given that we're going to lift things up, lift restrictions, are we going to track in detail? I mean, I asked about 2 months ago, shouldn't we at least know the occupations and the sectors and the categories of people who are getting it so we can understand where outbreaks might be coming? I mean, do you think that's a reasonable thing for us to know, or do we know?
The answer to the first question, do I think it's reasonable? Yes. The answer to the second question, do I know? I would get the same information as you do, Deputy.
Yeah, it's a bit of a problem, isn't it? Infectious control people don't actually know who's getting it. I mean, when we hear young people are getting it, is it young people drinking cans on the canal, or is it young people in direct provision? Do you know what I mean? There's a big difference between those two things, and we need to know them in order to be able to make informed decisions.
Do you want to ask the HSE? Because, I mean, we have people in Committee Room 1.
Yeah.
Do you want, does anybody want to come in from?
Deputy Boyd Barrett, yeah, just come in. This information is assessed as part of the ongoing surveillance by HPSC and discussed at NEFIT and at their once were daily press conferences. There's information given out in terms of occupation for healthcare workers, in terms of outbreaks, in terms of the background of outbreaks. So there is a lot of information collated by our public health departments on the positive cases, even when there are large numbers of cases. They're not exhaustive to the degree that you say there, that it narrows down to the occupation in one particular place, but they do give broad indications in terms of health workers, age, occupation.
Well, I'm just in my last few seconds. I'd like more information. For example, you know, I've been contacted by hairdressers. They're glad to be going back to work, but they're worried. They're worried.
Contacted one myself.
What?
I wouldn't mind being contacted by one myself.
Yeah. I had to take the shaver out myself to do this job. But the point is, they're worried about the guidelines. Are the guidelines adequate? How are they going to be policed? But surely one way to test are the guidelines going to work in different sectors is to know, is there particular outbreaks among hairdressers, among transport workers, among people who work in the airport, among school children if we reopen schools? That kind of information surely is critical. Isn't it? Isn't that a reasonable thing for us to know?
Deputy, outbreaks are tracked by public health departments according to where they are. And
for us to know.
Yes, this information is given out, and you'll know about the outbreaks in meat plants, in healthcare facilities, and this information is given out at those what were once daily press conferences by NEFIT, now twice weekly, and there's intense interrogation of those figures by media then, but certainly you also deserve to know, and if there's a report you need, Alan Smith, who's Deputy CMO here I'm sure will relay that to the NEFIT Secretariat and we'll provide you with any information you need.
So, will the information that Deputy Boyd Barrett's requesting, will that be made available?
I'm sure if any request is put in writing.
But as a general proposition, that information about occupation, age, that these sort of things, which in fairness makes a very valid case for, would that maybe be made available going forward?
I can certainly take that back to the Department of Health and NEFIT, and so there's always attempts to try and put across as clear and as detailed as information as is readily available. But certainly I can take that back, yes, and we'll certainly endeavour to make it as freely available as possible.
Very much. From the regional group, Deputy Shanahan.
Thank you, Chair. Dr. Mallon, firstly, on behalf of all of Ireland, can I thank yourself, Dr. Paul O'Brien and Dr. Oisin O'Connell, for the wonderful work you did very early on in securing PPE supplies from China, which were so badly needed in the teeth of this pandemic. Earlier you said the geographical spread will determine further lockdowns, and obviously we need the contact tracing and testing. I represent the constituency of Waterford, where we have thankfully managed the COVID pandemic very well, largely because of the provision of isolation rooms in the new Dunmore wing at University Hospital Waterford. But I was calling for potentially Waterford and the South East to be allowed to open in advance of Dublin, and that we were being pegged to what was happening in Dublin. So do you know if there's any plan? Let's say that, and I agree with you, we will have sectoral outbreaks in the country without a doubt, but is there any plan, and I know you're saying that you're looking for a written plan, but is there any plan that would allow regions of the country to continue to operate if there are clusters around the country?
So thanks, Deputy, for the question. I guess the short answer in terms of development of plans would probably be best addressed by our colleagues in the HSE, because they develop the plans. To date, I don't know of any that are in draft form that I've seen, but again, there may be others in the background that are being worked on.
Okay, thank you, Doctor. I might address some of the members of NEFIT there, if you please. Last night here in the Dáil, I asked Minister Harris to consider the mandatory testing, temperature testing of healthcare workers. I wonder, would anybody in NEFIT care to take that and just make a comment to it, please?
Deputy, already, as you may know, that there's the screening of healthcare workers going into as they enter nursing home facilities daily in recognition of the particular risk in those facilities. Our own occupational health lead, Dr. Linda Sisson, has provided guidance for healthcare workers and reminded them of their obligation through a message sent out repeatedly, and most recently last Friday, of their need to be alert for symptoms of COVID and to isolate themselves as quickly as possible. In terms of obligatory there's as yet not obligatory temperature taking of staff entering acute hospital facilities, but such a measure is of course under consideration as it happens in nursing home as in residential care already.
Dr. Henry, I might say to you that I've been involved in a number of large factory reopenings where mandatory temperature testing is required. And if we take the case of a hospital like University Hospital Waterford, we have 500 beds and we have 2,000 care staff transiting through there. So I don't think this measure should be delayed any longer. It's a simple zapping of temperature in the morning when healthcare workers are coming in and coming out. And I'm not sure why we are delaying on it.
I'll just ask Dr. De Gascon to come in, Deputy, if that's okay.
Thanks, Deputy. Just to add to what Dr. Henry has said, we're aware that, I suppose, organisations have started implementing this unilaterally, and we're conscious of the fact that there isn't guidance in the area. So we've asked HICWA to conduct an evidence synthesis for us in this area. As Professor Mallon alluded to earlier, it's certainly possibly one of a suite of measures, but we know in Ireland the majority, while temperature was a significant element of the disease in China back in January, we know that at this point in time, I think the majority of our patients in Ireland don't actually have a temperature associated with COVID-19. So HICWA's conducting an evidence synthesis for us at this point in time on the road of temperature screening to inform our practice and the possible development of guidance in the coming weeks.
Okay, thank you, Dr. De Gascon. Could I ask you just about airport and travel in and out of airports? And I know, I think Dr. Henry mentioned there earlier that there were newer screening techniques coming through which would shorten out the screening time. I'm aware of screening techniques that are coming through which will give a COVID response test in 20 minutes. Potentially. And what I'm wondering is if such a test can be made available, would NEFIT encourage that all people transiting into this country, particularly from affected countries, would have to undergo a screening test at the airport and await a COVID response test before they're allowed to leave?
Thank you, Deputy. As was referenced earlier, the rapid test would depend on its, to implement that would depend on its widespread availability across all airports and for all travellers. And as the information I have is that isn't the case at the moment. So the other test, the PCR test we do, it takes 4 to 5 hours, and to achieve that turnaround would involve detaining people at airports for at least that time interval. And as I said earlier in response to one of your colleagues, as we begin to reopen, and if we're going to resume passenger travel at the scale or even a fraction of the scale pre-COVID, we'd have to consider any measure we have, particularly coming from countries where there's higher levels of community transmission.
Sorry, Chair, just if I could just add, sorry, Dr. Henry, I'm talking about a COVID response test in probably 20 minutes turnaround time. And maybe I could catch up with you after the committee to have a quick word with you on it, if you please.
Yes, that's fine, thank you.
Thanks, Deputy Chairman. Deputy Collins.
Thank you, Chairperson, and thank you to our guests here today. I suppose maybe I have quite a few questions between the Department and the HSE to begin with, and all those later. In a question I put to the Taoiseach 3 weeks ago in the Dáil, he said that testing for COVID-19 cost us €200 a test. My presumption that was test results carried out in German labs. This morning you have said that they are costing €120. In my investigations I found labs in West Cork carrying out COVID tests for under €50. So everyone has a different figure. Why didn't you use these Irish labs who could have been up to 75% cheaper in testing?
Deputy, thank you. I'll ask Mr. Damien McCallion to respond to that, if that's okay.
Yeah, so Deputy, there is variation in the rates that are paid, and there's different rates as well, even within the tests we use within our own hospitals. They vary quite significantly in terms of the costs. So when we looked at trying to get that 100,000 capacity, we looked at where we could get high volume in order to deal with that sort of volume that's going through. All laboratories, I suppose, that we use have to be accredited and working under a clinical laboratory service. So we looked at all possible labs in country and out of country, but we needed high volume labs for some of our community testing so that the systems that were there would ensure we get the results through in a timely manner. The rates we're using, we are being very careful in terms of the commercial rates because we're still negotiating with those, and clearly we don't want to prejudice those discussions. But we're happy that we've got good competitive rates relative to the rest of Europe. The cost in terms of that you're referring to there doesn't refer to the German laboratory. Their rates are competitive, the same as all of the on-island rates. And as I said, there's quite a degree of fluctuation, often down to the nature of the test itself. But there's other factors as well in terms of not just the cost. We have to make sure all the IT is enabled, from the GP referral through to the appointment, through to the lab result coming through and going back into the contact tracing system. There's a very sophisticated IT system that's been built up as we've moved through this process as well. So we've engaged with all possible laboratories, and we were getting at one stage 50 to 60 leads a day, and we had a team who tried to sift through all of those and identify those that would give us the quickest return. But all laboratories, and I may be aware of the lab, I don't want to probably get into it here, it wouldn't be appropriate, and I'm happy to take it offline, Deputy, but we have engaged with every possible laboratory who could offer a service to see what's there. But at the moment we have that capacity, and was mentioned earlier, the volume is running at a lower level.
Thank you. I was told here last week at a Covid-19 meeting that testing has cost in the region of 500 to 600 million. Did this factor in the purchase of a PC-12 plane by the Air Corps to take Covid tests to Germany?
So I think the costs that were referred to there, Deputy, were if we were to run 100,000 a day, every day, that would be the cost to the end of the year. Clearly that's not the case. The capacity was built to deal with those surges, not for every day. So the costs at the moment are under that, and I think they're set out in the briefing paper that we provided today. So we've used the Air Corps just on a very small number of cases when there wasn't courier services available from Dublin Airport, which is built into our price, and they've been very helpful. And I want to recognise the Department of Defence and the Air Corps for their support at times, not just indeed on the transport of samples, but also on our contact tracing, where the cadets were very helpful to us and invaluable in the early stages as well.
Have you looked at investing in Irish labs so they can up their testing capabilities at a fraction of the costs that we've spent to date?
Yeah, so Deputy, just to say, the bulk of the cost that we've invested to date has actually been in Irish laboratories. Just in case there's any doubt on that, the bulk of that has gone into either our acute hospitals or some of our other labs, like our colleagues in NVRL and other associated laboratories. At the moment, as Niamh has said earlier, we're developing a strategy which is trying to beef up the capacity on island to cater for, as Dr. Mallon said, for example, the flu season next year, other potential surges, and how do you build that in a sustainable way? And it isn't just a case, unfortunately, of purchasing the test. It's all of the staffing, the logistics, the infrastructure, the buildings, the IT, which is crucial. I mean, you mentioned, one of the deputies mentioned earlier in terms of the learning, not having all of that technology and trying to build it as you move has probably been one of the biggest challenges, and we're still continuing to invest in trying to improve the turnaround times through all of those little small process changes that are there. So there's a very significant investment, and the bulk of the costs that are set out in the paper with yourselves are actually in our own services here on island.
Thank you. And I've been asking the Taoiseach and the Minister for Health in the last number of weeks to create a system where we can have quick turnaround testing at our airports and ports, obviously to open up our areas and make people feel comfortable that people are coming in are COVID-free. The Animal Health Laboratory in Bandit I visited recently can have results within 4 to 5 hours, as I assume other labs can do at the same costing under 50 euros. Why are we not putting these test centres in place at our airports and ports?
As I answered earlier, Deputy, this is a matter we have to obviously give serious consideration to as our airports open back up, and it's being discussed at NEFIT, so clearly it's something we have to seriously consider. I can't give you any further information at the moment because it will inform our overall testing strategy, but clearly all the more important as we begin to open up travel into our country.
And just a final question, why are our doctors and nurses in local clinics and hospitals not able to carry out COVID-19 testing?
There would be, Deputy, in the sense that local hospitals, for example, we have, I think it's over 40 plus hospitals testing. It isn't just a case of doctors and nurses, like you need the laboratory services, you need all of the other elements. Like the tests are relatively complex PCR testing, while there's a number of things you have to have in place in order to undertake the test. So I'm not sure if there's a particular hospital maybe you have a query on we could follow up on, but in general there's a need for the scientists that Dr. De Gascon has referred to, all of the equipment, which can be quite expensive, the reagent, etc., the IT systems. So if there are some hospitals that aren't testing, it's because those situations are there, but they're very clearly aligned to a bigger hospital or a hospital that's close to them. Like, we've over 40 plus hospitals in the country testing, and most geographical areas are covered.
Thanks. Are we still paying for testing that we're not utilising? I mean, at the start we had to, as a state, book a certain capacity, but that was to run out at a certain point. So are we, on an ongoing basis, paying for testing that we're not using?
We're managing that very carefully at the moment, Deputy, so we're not incurring costs, I suppose, over and above, by and large, what we are testing. We have had to stock up, obviously, in some cases. So for our own public hospital systems, for example, we've tried to purchase ahead so that we're not essentially caught with some of the problems we had at the start, so that we have a stockpile that brings us forward in terms of reagents and test kits and so on. So certainly we are advanced purchasing in some cases so that we don't get caught with supply chain difficulties further down the line as well.
Okay, but we're not paying private labs for X number of tests, even though we're only actually utilising a fraction.
At the moment, we're not in that position, but it is a challenge, Deputy, and to sustain it, it is inevitable if we want to sustain capacity, whether it's private or public, that we will have to pay some amount towards that. But at the moment, we are sort of working with the laboratories to minimise anything around that, and it's not an issue at present, but it is something that we're conscious of. And we also have to be aware that, I suppose, where lab capacity will become a problem again is where there are surges that Dr. Mallon referred to earlier across Europe, and we don't want to be back competing with bigger players than ourselves, trying to find capacity, reagents or supplies from big global companies. So it's a challenge both for the private labs, but also for our own public laboratories as well.
Thank you. Deputy Duncan Smith, if you're...
The national rotation go through.
Well, we're just going to go to the second speakers from the bigger party. So,
no,
okay, go ahead.
Go ahead. Yeah.
Deputy O'Dowd, is it? Are you taking 10 minutes or 5?
Yes. Can I ask initially? Could I get a note, please?
Sorry.
Sorry.
Well, sorry. That's clear. 5 and 5. Deputy O'Dowd.
Oh yeah, sorry, I didn't realise you were there. Sorry. Yeah, sorry. Can I ask? There's no problem here. Can I? This is an important question. Can I get a note, please, on the number of people that are working currently on contact tracing, and the number of volunteers, and if we have, how those numbers have changed over the period of time. The second one, can I ask for a note, please, on the difference between the use or the recommendation of face shields versus face masks. There's a number of people have been on to about the use of face shields because they feel that you can speak in them and they're easier to wear than the mask that you can't talk through. The other question is, in relation to the relationship between the United Kingdom and Ireland, there are different rules in both jurisdictions, depending on whether you live in the north or the south, or you live in the UK. And do you not think that we need to address this issue in a significant way? Because people travelling to the UK through the north, when they return, they don't have to fill in any forms as they come back through the north, whereas people from the UK coming in here do through the south and not through the north. So there are serious ambiguities there. The third question I want to raise, and this really goes to the key point, would you agree that in view of the fact, and I agree with Professor here about the problem that will be exacerbated by the flu if it does come, and obviously a return of the pandemic, what should we do in terms of the flu vaccine? Should it be mandatory completely, or should it be available to everybody free of charge, or particularly health workers, older people, and so on? And the other question I have is it's a very important question. The World Health Organization tells us that people over 60 or people with underlying conditions should use medical grade masks. If you go to buy medical grade masks, you're told in the papers that they're not available. And secondly, you can go into Dunn's, you can go into Lidl, you can go into your chemist. You don't know the quality of the mask you're actually buying. And if these people, people over 60 and underlying conditions, are at a greater risk medically, surely it is incumbent on us to make sure, A, that those people get them, and if they're on low income, that they get them obviously for free. And secondly, that the masks that they do get are meet a grade is of medical need, if that's what the recommendation is. So they're the main questions. I have.
Thank you, Deputy. I'll ask, just go quickly through your questions, Niamh O'Byrne to answer the question on the people in contact tracing, and I might ask Killian de Gascon in his role in the expert advisory group to comment on the shields versus masks, or supply you with the information if we don't have it to hand. So.
Thank you, Deputy. So for contact tracing, 16th of March, we set up 9 contact tracing centres and we trained 1,700 people. 300 people were deployed into the public health departments to support them in contact tracing, and up to 700 in the 9 centres. At the current point in time, we have consolidated our contact tracing centres into one centre, which is in Galway, and they are operating at around 34 staff. That staff number can comfortably do 100 positives per day, and if you think about yesterday, we had 5 positives. So they're there and capable to do much more than we have currently to do. The agreement that we have, as I mentioned earlier, is that once we get 3 consecutive days of 100, we would either open up other test centres or remotely ask contact tracers who are trained to step up that capacity again.
Masks versus shields, or if it hasn't been considered, we can supply information.
Thanks, Deputy. So the issue of mask versus shield, we haven't looked at that specifically. Obviously, shields don't provide the same level of contact with the skin, but it's not an issue we have considered, but certainly we can look at it and revert to you.
Thank you.
The other issue, Deputy, on the flu vaccine, we're extending the flu vaccine this coming winter to younger age groups in recognition of that they're an important reservoir of flu, even though they're often not affected as severely by the flu. So that was that order was put in and secured by the HSE a month or so ago. We are also focusing on our healthcare worker updates. That's improved significantly in recent years. It is voluntary, as I'm sure you're aware and you're alluding to, but it's gone from 30-odd% up to 60%. It needs to improve further. There'll be a big push in this. As regarding whether this should be
mandatory
or not, that isn't really a decision for us. Clearly, as
you have a view on it.
Wearing my health hat, and my own belief is that it should be mandatory. But it's not that to me would be a policy decision. But speaking, as I say, with my medical hat on, I can't see why any healthcare worker wouldn't get it unless there's a specific contraindication.
Sure, Professor, I'd like to answer.
I guess just 2 points I'd like to make. I'd agree that the flu vaccine should be mandatory for healthcare workers. I would also fully support an expanded availability of flu vaccine as a public health measure. The one thing about public health measures in general is that an expected uptake of any public health measure will always be dented if it comes at a cost to the public. And that could be either provision of vaccine or provision of masks, or, as you say, provision of a higher grade, more expensive mask to certain areas of the population, particularly members of the population who may not have the financial stability to be able to secure that. And I think that any consideration around public health measure needs to take cost into account. And if it's something that is expected to be widespread and expected to be effective, as both the flu vaccine and mask use will need to be if they're going to be useful, then really you need to examine whether or not it should be made freely available. Because it's only by doing that you'll get the maximum impact from the intervention.
As is well known, we face considerable shortage of PPEs in this country, and we're able to secure supply lines. But at that time, in recognition of the particular risk in healthcare settings, it was introduced for healthcare workers, and the WHO reflect this in their guidance, saying, recognising, I suppose, the particular importance of providing and having a supply of masks for healthcare workers. But now that we've secured a more promising supply, we would have to factor in how much more we'd need for particular at-risk groups in the community, and to secure, to make sure that they feel safe and that they have access to those masks free of charge. But it was considerable efforts for us as a country to secure what we needed in terms of PPE and usage for healthcare workers in our hospital and community system.
Thank you very much. The second Fianna Fáil speaker, are you speaking for 10 minutes or 10 minutes?
And firstly, I just want to thank all the witnesses who are attending again today and for the documentation provided. Professor Mallon, if I could start with you, please. You stated in your opening statement that lessons learned from the first wave of Covid-19 need to be translated into actions and resources, and that we have a very narrow window of opportunity. As we look forward and try to learn from the last 3 to 4 months, what lessons do you believe were learned, and where do you think we need more resources directed as we face a potential resurgence of the virus?
Obviously today, thank you Deputy for the question. Today we're talking about the contact tracing and testing piece, which I think we've underlined how vital that is as a component. Moving forward towards the early autumn, what's going to be really critical is our hospital setting. People in Ireland will expect to be able to attend a clinical care facility and be treated in a safe environment, and it's paramount that we maintain safety within our hospitals and prevent COVID-19 infection entering the hospitals. Two main ways that the COVID-19 will enter the hospital will be patients attending the hospital through the emergency department or through outpatient clinics with symptoms, so we need to pick people up at that stage, and staff attending the hospital unwittingly bringing the infection in. These are lessons that we've learned from the first wave. At the moment, we don't have a clear process in place to be able to at least deal with the staff issue, in my view, and that's part of the idea around the need for this written end-to-end strategy, testing strategy. And secondly, as we retreat rapidly from our use of private hospitals, there is an expectation that we're all going to be able to squeeze back into the same healthcare footprint that we had back in March, be able to deliver the same services and be able to deliver that in a safe manner. And frankly, Deputy, I can't see that being realistic. We have emergency departments where the footprint is far too small. We had a trolley crisis that went on for months on end up until March, where we had in excess of 900 people and some days on trolleys, where we're unable to physically distance within the emergency department. So even with the adequate testing and turnaround in hospitals, the environment currently within a lot of our hospitals is simply not adequate to be able to safely manage increasing community transmission of this infection. We have a window now to fix that, but the window, in my view, is between now and September. Because it's really at that stage that I would expect cases to increase.
Thank you, Professor, and I agree wholeheartedly with you that critical planning now is essential, because we're facing into a winter where we're going to have COVID patients and non-COVID patients. Then we could have the normal winter surge, the winter vomiting bug, the winter flu, and we all know that, you know, it's something I've raised consistently for the past 4 years: late discharge of patients, late transfer of care, and the amount of bed days lost as a result of that. And it's something we discussed here in the Dáil last night with Minister for Health, and I actually believe that we have to put a clear emphasis on true flow through the hospital, that when patients arrive, that patients that need to be you know, sent home as a matter of urgency, that the correct wraparound supports can be put in place for them. Professor, you also stated, you referred to the memories of those who have died from COVID-19, some avoidable. It's something I've been raising consistently in this committee. If patients were tested prior to entering residential care throughout March and April. So we know, for example, 1,300 patients in March were transferred from the acute hospital setting to nursing and residential homes. And we know this virus has borne down hardest on our older people, with 63% of all deaths occurring in residential and care homes. You speak about avoidable deaths. Do you believe if these patients had been tested prior to entering into nursing homes, some deaths could have been avoided?
When I refer to avoidable deaths, it would be, in my experience, when an individual attends a hospital without COVID-19 with another illness and enters the hospital environment sick, they don't expect to contract COVID-19 and die within that setting. We need to maintain safe environments for the public to be treated for their illnesses. And that, to me, from a physician and I think from a societal level, is really critical. Whether it be in acute hospitals or whether it be in nursing homes, the same thing applies, because the consequences of the sick, the vulnerable and the old acquiring this infection is death. And that's a fairly stark consequence that we simply cannot accept. We can talk about bed days, we can talk about social distancing, but if we enter the September, October, November time, knowing what's coming, and we still end up with people dying within our healthcare facilities from nosocomial infection, then in my view, we have failed.
Do you accept that if the capacity had been available in March and April to test people who were being transferred to residential care from the acute setting, I understand that we were learning, everything was done in good faith, capacity wasn't available, but I firmly believe myself that if the capacity had been available and if patients had been tested prior to being returned to a nursing home, they could have been isolated for 14 days. It would have certainly made a difference.
I think that there are a number of factors that probably contributed to what happened in the nursing homes. And the first thing that I would like to say is that, having had experience of actually going out and visiting nursing homes during the pandemic, there was a huge variation in what was happening in nursing homes. You could have a nursing home in one district that was being decimated, all staff, all patients being affected with Covid-19, a number of people dying, and yet you could travel down the road 200 to 300 metres and you would see a nursing home that was completely unaffected.
Okay.
So I think we can talk about the nursing discharge, or the hospital discharge, the nursing home bit, but it's not the only story. There's certainly something at a managerial level within nursing homes that some nursing homes were able to do excellently and maintain the safety of their residents and their staff throughout the whole pandemic, while other nursing homes were unable to do that. And I think that, to me, is the key. What were the nursing homes that avoided this? What were they doing right? And we need to learn from what they did right and make sure that all of the nursing homes follow those sorts of practices, because they worked.
Thank you, Professor. Dr. Henry, if I could ask a question, please, in relation to the ongoing testing now in nursing homes. Obviously, we know test, trace and isolate is the mantra that we have to learn by. Now, we understand that medical staff in nursing homes will be tested for the next 4 weeks, which is very welcome. But could I ask you why the other staff in the nursing home, so for example, the caterers, the housekeepers, and also the patients, do you feel it's sufficient, and this is a question I'm just asking, do you feel it's sufficient to test the medical personnel only and not test the rest of the staff and patients in the nursing home setting?
Deputy, all staff are being tested, including the disciplines you just referenced there. So we're not confining it to the disciplines you mentioned. But could I just add very quickly, based on your previous remarks on the testing and transfer during that month, that in the past 100 days, we've learned so much about this virus from a very low base to a lot. I'm speaking now with my clinical hat on again as a geriatrician, that what we know now, we didn't know then. It was the importance of atypical presentations in older people and asymptomatic transmission. And remember that testing was directed by the case definition. So people who conformed to the case definition, which was originally quite narrow, then depended on the presence of a fever and respiratory symptoms. That guided testing. And what we know now, and only became clear through international experience throughout towards the end of March, was the importance of atypical and atypical presentations in older people and asymptomatic transmission.
Thank you, and thank you for the clarity, because we received different information last week when we were informed that only the medical personnel were going to be tested. It didn't include the housekeeping, and so
all personnel, Deputy.
No, I thank you for that. But again, I'll go back to the point. Do you not think the patients should also be tested?
Well, there was a blanket exercise in testing patients, all patients in nursing home facilities, which was the order, I think, of 30,000 odd, and that was carried out in April. And to go back to what the test actually does, it's a point-in-time information. It tells you something about this particular time on a particular day. It doesn't tell you anything but the following day. What we are doing in the next 4 weeks is doing serial testing of all healthcare workers, including all disciplines you mentioned there, in nursing home settings. So that's to inform us about, in a deeper manner, about the mode of transmission, the behaviour of this virus among healthcare workers who have the power to transmit this virus while asymptomatic. And that has been potentially an important source of transmission in a very vulnerable healthcare setting.
Thank you. And my final question, according to your opening statement, Ireland is one of the few countries to offer automatic testing for contacts of a confirmed case. And how important is this to control the spread of the virus? I know one of the other speakers said that you test on day 0 and day 7. Do you think this is something that we need to continue doing on an ongoing basis, and how important is it?
I'll give you 2 figures, Deputy. Among symptomatic contacts, the positivity rate was 14% so far. But this one is on the next figure should underline how important this is. Among people who have contacts who have no symptoms, the positivity rate was 9%. So for that reason, we need anybody who's a contact, and we are aggressively pursuing all contacts. We need them to engage with testing, be tested, because just because they don't have the symptoms they don't have symptoms doesn't mean that they don't have the virus and couldn't potentially be transmitting it to other people.
Thank you very much. Thank you, Chair.
Thank you very much, Deputy Butler. Deputy Carthy, you speaking for 10 minutes?
Cahirlock, we received a submission this morning at 9:32 in relation to testing and tracing from the HSE. That submission is actually dated the 16th of June. I wonder if the Business Committee would just do an examination in terms of the reason why it arrived so late. Was it from the HSE or was it just a bureaucratic issue? Because clearly it's difficult to engage in questions to witnesses when you get a document 2 minutes after the meeting has started. So without making a big issue of it today, it's just maybe something the committee will look at on Friday. Just in relation to questions, and I want to thank again our guests for coming here, Professor Mallon and Dr. Henry and his team. We know you're all very busy people and we do appreciate you being here. Dr. Henry, if I could ask in relation to workplace instances, we've discussed meat plants previously. And when Dr. de Gascon was here previously, I had asked him whether or not there was any other specific type of workplace outside of healthcare centres, other than meat plants, that had seen a prevalence that would cause concern of COVID-19 cases. I think Dr. de Gascon's position was that he was unaware of any other workplaces. Can you confirm that meat plants were the only workplace where we saw a prevalence of cases outside of the healthcare services? Excuse me.
Good question, Deputy. Just bear in mind that if you remember all that the essential services, meat plants were included in those when as we gradually closed down, the social measures kicked in on March the 12th and March the 27th. So there were many other workplace settings that either had gone back to home-based working or just closed down completely. But that said, if you look at our own experience here, it's being replicated abroad. You'll have seen in Germany the past week a significant outbreak in a meat factory setting similar to what we've experienced. So the predominant, I'm not aware, Deputy, I'll come back to you just to be sure I'm giving you accurate information, but I'm not aware other, if you like, clusters of a particular workplace setting other than meat plants and healthcare facilities. But I'll come back to you with more accurate information from the HPSC.
Thank you for that. So recognising that meat plants have been a particular issue, and as you say, it's not just in Ireland, it's actually internationally, and for obvious reasons, they have been a particular issue. What level of focus are your team keeping on meat factories to ensure that we don't see other spikes in cases within those settings?
Well, it's huge, and you have raised this before, Deputy, and it's absolutely correct. It's that it's a very vulnerable setting, and a particular type of configuration of the workers there that are often foreign, sometimes and often English, not the first language, and the mode of transmission, Deputy, is as likely, if not more likely, to have taken place outside the work setting. In other words, in how they live and in congregated settings and so on. We have a public health lead, Dr. May Mannix, who's led on this and produced a report for NEFIT, which I'm sure we'll be happy to share with you, giving a summary of the total number of outbreaks, the total number of workers affected, which I think is now over 1,000. Again, I can supply you with exact figures. And the management of a deputy was predominantly by a focus element of our public health workforce, led by Dr. May Mannix, who liaised with the owners of factories, Department of Agriculture, directly with the workers themselves, translators in many cases, particularly Portuguese and other such languages, and it was a considerable undertaking.
Is that work ongoing in terms of? I know the prevalence of cases seems to have reduced in those settings. Is the work and monitoring by the HSE and the testing and tracing teams ongoing in the meat factories?
It is, Deputy. Unfortunately, we've seen a marked reduction in the number of outbreaks as community transmission has fallen. But the events in Germany, as I say, underline how transmissible this virus is and how quickly it can get a foothold in a workplace setting such as a meat plant, where there's other factors playing into transmission, not just people working together. But to reassure you, Deputy, part of the measures brought in by the public health team was looking at staggered shifts, smaller groups of people working in hubs, and there were measures introduced in cooperation with the meat factory owners.
Thank you, Dr. Henry. And if that report could be provided to the committee, I think it would be very useful. Just in relation to healthcare workers, Philny Hay from the INMO was with us the other day and made a very powerful presentation. I felt she had made the comment that I think stands up to scrutiny, that within Ireland the prevalence of healthcare workers was the highest in the world in terms of cases of COVID-19. The Taoiseach has tried to, I suppose, undermine those figures by quoting a different set of figures. Do you accept that in Ireland the prevalence of healthcare workers as an overall percentage of the population that received COVID-19 is the highest in the world?
Deputy, very briefly to add, the concern is as much to me personally as it is to you and to everyone in the HSE and to unions and Finlay Hay and everybody else. I don't accept the characterisation of it. That said, while every single case will be troubling to any of us who work in the health service, given that we have friends and family and otherwise working as frontline healthcare workers, and it's simply because if you look at the denominator, the number of people we tested throughout this whole pandemic, it varied. At one point, we were testing small numbers of people based on the difficulties we had securing testing equipment and laboratory facilities. But at all times, we prioritised healthcare workers. So
that's not up for discussion at this point. I'm just asking, in terms of the basic tenet of the point that was made, do you accept that in Ireland our percentage rate of cases that were among the healthcare sector was the highest in the world?
I can't accept that we can compare like with like, country with country, Deputy. That's what I'm saying to you. So I don't dispute the figure of 32%, because that's. But what I would say to you is, because we will be measuring healthcare workers as a priority from the absolute go, even when we had testing difficulties, and because we had a very wide definition of healthcare workers, much wider than other healthcare systems in other countries, that to me that's as likely a reason as. I have
other questions. Do you accept that 32% is too high, that we really need to strive to improve that figure?
Any case is something, not just a disappointment, but it's a huge risk for us and for our healthcare workers. So any case is wrong, and we have to do whatever we can to protect our healthcare workers, be it with PPE, with masks, with infection prevention and control measures, education and training. And many of these cases took place outside acute hospital settings.
Thank you. Professor Mallon, I wonder if you could just give me briefly your opinion. There's been a number of calls, and we heard this at our committee another day, for a change in the regulations that would categorise instances of COVID-19 that were contracted in the workplace as notifiable occupational illness that would then be notified to the HSE. The Minister for Business could change the regulation essentially at the stroke of a pen. Do you think that that should happen?
I definitely think it would be a useful addition. What we really have no sight over at the moment at a national level is the impact on a workforce of a large number of people within that workforce contracting COVID-19. I know anecdotally from my own personal experience, having run a follow-up COVID clinic now for the last 5 weeks, that the vast majority of attendees at that clinic are healthcare workers from a variety of different settings, the majority of whom didn't contract a sufficient initial disease to require hospitalisation. So people acquiring a flu-like illness that we talked about, that are sitting 3-4 months down the track still not recovering. It's really vital for our economy that we recognise the extent of that, the nature of it, and be able to characterise it, because there's absolutely no reason why healthcare workers as a workforce should be any different in terms of their recovery from any other part of the workforce. And for example, if we're going to open up our economy, we need to know the expected impact in terms of absenteeism and recovery times of any resurgence in cases in the community.
Thank you, Professor. Just back to the HSE, I have less than a minute. In terms of, we know what the capacity is, or at least what we hope the capacity is. Do you have a figure, Dr. Henry, for the highest daily number of tests that were carried out throughout the pandemic and the equivalent number for the week? So the highest number of tests that were carried out in any given day and in any given week.
Deputy, I know we peaked at over 20,000 in one day. I can't, again, I'll come back to you. These figures go back to mid-April, so they escape my memory now. But we did peak during I suppose, the peak of community transmission at huge numbers. I might ask Damien.
Finally, because I've literally just a number of seconds. Do we yet have any analysis or number of the number of people that entered into healthcare settings where we presume that they didn't have COVID-19 and then subsequently contracted the virus within the healthcare settings? Do we have an analysis of that as yet?
No, I'd have to ask you, Deputy, to give me the specific question there, because I'm not.
The number of people who entered into say a hospital setting or other healthcare setting without COVID-19 that subsequently contracted the virus. And I know you can never say for definite that somebody didn't have it, but presuming that they didn't have it, what the numbers would be.
It's somewhat difficult, Deputy. We have done analysis of healthcare workers, for example, who are usually self-reported, but whether that means they're contracted in the healthcare setting or in the community is unclear. And for this,
my question relates to patients.
For patients, an analysis, we carry out an analysis of every case to try to see what was a community acquired or nosocomial, let's say healthcare acquired. As I say, it isn't always straightforward because of the number of contacts patients will have had, or because of the exposure patients will have had before when they came into hospital and when they first developed symptoms. So there will be limited information on that.
Thank you very much. Deputy Brophy, minutes.
And I'd like to start off with the HSE and just a couple of things. First of all, just I suppose to put on the record again our thanks for all the work which everybody throughout the entire HSE and our entire health services has done. I, for one, would like to make a couple of quick points to you. I'm very supportive of the testing programme and the work that was done in getting the labs, including the German lab, aboard. I believe it is vital that the HSE continue to seek to deliver that service in the best possible way, not be influenced by the individual requirements of companies in different parts of Ireland looking for business, no matter who's selling it on their behalf. I'd like to see that the HSE would continue to provide that service based on the best possible clinical practice and the best possible resultant outcomes. I think that's important to put on record here. I also, though, would like to ask you one thing in relation to testing, and I'm conscious of the time being very limited. A number of times you've answered, you have capacity for X. A number of times you've said that we've had up to 20-odd thousand tests being done in a day, etc. Now our requirement numbers are much lower. Now maybe this is a real layperson's view on this. What I can't understand is this. If the numbers being tested have gone so down because of lack of community transmission, why can't you still get that turnaround figure to a day? You quoted earlier on, much earlier on in this session, the medium figure. You quoted the actual number of days in terms of averages as well. But if the infrastructure was there, and you say it can be turned on at the drop of a hat, if you have existing infrastructure, which I actually think one of the HSE people said was excessive what's needed for the capacity at this moment, why is it that we're still not delivering the turnaround times in the community that we're actually doing in, say, a hospital setting?
I'll ask Niamh Byrne to come in on that, Deputy.
Thank you, Deputy. So the process in the community is different from the hospitals. When you feel unwell, you contact a GP. The GP then has to refer you for a test, and you get a call or a text message to organise a test. And then there's a time for that test, depending on where you are in the country and your own availability. So we
absolutely. I'm sorry. I know all that because you've said it already to other deputies. I'm asking you this question. Are you, in a simple answer, saying to me, because we've been told we should be doing it in a day, are you saying that's not possible?
It's not possible in that referral pathway because the laboratories turn it around within 24 hours for the vast majority of cases.
So what do you say to people who say you should be doing that in a day for the system to work?
Well, our targets that we set for ourselves in early May were to do 90% of tests within 3 days and to do the referral to swab within 2 days. And that we are achieving the metrics we set out to. Our community settings have that.
I'm going to ask you what you say to people, including our other witness here today, that say these type of things should be done in a day. Are you just blanketly saying that's not possible, we cannot do that?
In our current infrastructure and our process, it isn't always possible to achieve that.
Okay,
for example,
should it be possible to do it?
We would, when we're building the new longer-term operating and testing service, we will look again at our metrics, we will look at again at our pathways, but at the current moment, from the
I hear what you're saying. Is it the objective with the new system you're bringing in that goes live in August to bring that down to 1 day?
We will look at that objective in line with what we actually build and we feel is feasible within our country and our country's ability to have laboratories on site within our shores, and depending on the volume then we expect to have also. We have to build something very flexible, to be able to go with small numbers of tests per week, but also be able to flex when we get into winter and when we're in the middle of a flu season.
Yeah, I hear all that, and unfortunately, as other deputies have alluded to, because of the time restrictions we have, is it the objective in the August rollout to have a 1-day response time, and is that the most desirable situation to be in?
We have not defined our KPIs yet for that piece of work. It's only just begun in the last week or two. We're currently meeting the targets we set for ourselves, and we will look again at what we believe from our country and the pathways in which we can have testing, what would be a feasible and most desirable. There are varying views on what is to be achieved.
Sorry, go ahead.
I have one other very quick area I want to go into. I'm very worried, and it's not in relation to yourself, Ms. O'Byrne. It's on a just different point. I just want to finish it off. With testing coming into the country on airports, there were a number of people trying to sell, I think, what I have come across as kits that do these 20-minute tests, that do 40-minute tests, that do an hour test. Most of the international research so far is very, very dubious on the effectiveness of those testing. I would be very anxious that the programme that the HSE would be advising, that NEFID would be advising, would be the development of air corridors with areas of like infection, rather than going down some half-baked testing idea that gives us no real protection. I mean, to be honest, I wouldn't have anybody coming in from the United States at this moment, whether they passed any test at all, be it a 40-minute test or a 4-hour test. I don't think we should have people coming in from the United States into our country. And I would be interested just to hear very briefly that the view would be, what I would hope it would be, that we would stick exclusively with like-for-like
very briefly, please.
Very briefly, if I could.
Sorry. Very briefly, Chair, I agree with Deputy Brophy, and it's been referenced before, the test is a point in time. And when you look at tests that are being offered and perhaps not always validated or not used, they may not have complete sensitivity.
And on the issue of the United States, or the north of England, for that,
there's marked geographical variation within the United States. So, as with any other,
let's say Texas then, or the north of England, where there's a high incidence.
Clearly, it's not just the issue of testing; it's the quarantine when people come in, because the testing will miss cases. It's not 100% sensitive, and a rapid access test to which the deputy refers.
Thanks very much, Dr. Henry. I'm just anxious to get in Professor Mallon, and then we'll move on to Deputy Smith.
I guess 2 quick points. The first thing is that the public should be warned against doing any test that isn't officially validated, because the public may undertake, for example, an antibody test that would be 20 minutes that really tells you very little, and think that they're getting the reassurance of actually having a point-of-care nucleic acid test. So we really need to put the message out there that you need to get tested through the official channels so that you're tested right. And we do need to be careful, as I've said previously, very careful in terms of allowing people from the outside into the country. If we allow unrestricted movement of people from any area of the world, whether it's the United States, whether it's South America, whether it's parts of Eastern Europe or Asia, where there is uncontrolled community transmission, we will be making trouble for ourselves.
Thanks, Professor Mallon. Deputy Duncan-Smith.
Chair, my colleagues and the witnesses for being late to today's session, and if any of my questions are repetitive or have been asked before, my apologies. I'll be quick because I know time's especially against us. In relation to the tracing app that's currently being tested, we understand, by the guards, when do we have a view on when that will be ready to go? Are there any GDPR concerns regarding its use? Will it be free and available to sports clubs and community groups? My next question is, the HSE working towards a test from home model? If so, how would that work? Would testing kits be free to all? Thirdly, were there many instances of members of the public who refused to engage with the tracing process? And if so, what were the consequences of that, and what learnings can be taken from it? And finally, where we've seen the virus re-emerge in other countries, they have re-emerged in kind of super spreader events on either on public transport or in clubs or something like that. Are we confident that our testing and tracing system, as it's currently set up, will be able to respond to that kind of super spreader event at short notice in a particular location? Thank you.
Thank you, Deputy. I can take the questions in relation to the app. I can confirm that development of the app is complete, and the app, in a technical sense, is ready to be deployed. The purpose of the app is to enable the health services to improve the speed and effectiveness of contact tracing. And it has three basic functions: the contact tracing, a symptom tracker, and it will serve as a trusted source of information in relation to COVID-19. It will add value by identifying more contacts than is possible in the manual tracing process, and this particularly applies to strangers that might become close contacts, and those cases will increase as we normalise and return and lift restrictions. The issue of timing has featured very much here today, and the app provides a capability to provide rapid notification to all close contacts who are app users within 3 hours, and that's a very significant gain on the alert and the guidance that'll apply. The app will absolutely be free to all citizens. It's a population health initiative, and one that we want all citizens to engage with. In that context, we have arrangements in place to have English and Irish versions, and have worked with the National Council for the Blind of Ireland to ensure that kind of full accessibility. The app has two critical success factors as we assess it. One is the obvious one, population take-up, but the other one is interface with the testing and tracing services. And on the interface with testing and tracing services, I can assure you that enormous work has been done to plug it in properly into the wider testing and tracing operation. The issue of population take-up brings us very much to the GDPR issues and the assurances that people can have about their privacy being managed in how the app is designed. We have taken enormous care to ensure maximum privacy. The development of the app over the last, say, 12 weeks or so has been a journey towards the maximisation of privacy. The Irish Council for Civil Liberties and others have contributed substantially, setting out key principles that need to be observed, and we're very confident that we have observed all those principles. The app is voluntary. It operates a decentralised architecture that avoids any data being held centrally by the health services or the governments. Additional data of statistical value is provided by users on the basis of user preference. All the details about the data and the privacy considerations are set out in a very detailed DPIA, Data Protection Impact Assessment document. We completed that a number of weeks ago, and it has been considered in great detail by the Data Protection Commissioner, who has responded. The Minister has committed in the Dáil, and HSE have committed in statements over recent weeks to making these publicly available, and it's our intention to make these publicly available tomorrow morning. So that will be good in terms of the transparency, and it will set the ground.
Dr. O'Connor, maybe you could provide, or Mr. O'Connor, you could provide the additional information to Deputy Smith by way of writing, and I do appreciate the detailed answer you're giving. Just, it's open source, is it?
No.
Yes? No.
Open source?
The app?
No.
Oh.
I don't understand the question.
Will the app be open source? Will people be able to look at the coding in it?
Oh, the source code, yes, Deputy. Sorry, yes.
Oh, okay.
Source code will be.
Were there other questions that Deputy Smith had?
Yeah, I can take them in writing, that's fine.
You'll take them in writing as well.
Yeah, yeah.
I just have two quick questions, and I know Deputy Boyd Barrett has a question as well. There was a lot of information provided by the CSO recently, but it was obviously retrospective on geography, gender, socioeconomic background, occupation, all of that, of people who tested positive and people who unfortunately died, age. That was useful, I take it, or would be very useful from your perspective?
I think all of this information is useful when you're trying to plan, especially at a population level. One of the aspects that I think will probably become apparent in this is as we protect our health services, for example, when you look at the pay, the living conditions, the overcrowding of the people that some of the people that are actually working in the health service, how that contributed to the overall epidemic will be an important factor, and I think that data will feed that conversation.
Thanks, Professor Mallon. Would it be useful to receive that information on an ongoing basis?
The more information that are made available to society in general, together with the people that are managing the epidemic, would be useful, yes.
Can I just ask the NPHET and the HSE if that information will be provided on an ongoing basis instead of being provided retrospectively?
Certainly, I can say that the Department of Health website now has a lot of information being increasingly publicly available, including a lot of the demographic data, incidence of cases and a number of laboratory tests, and maps as well of where cases are happening. I can certainly direct the committee to that specific website and or specific part of the website so that they can examine it and see if the information on it is sufficient. But we'd certainly be anticipating adding to that.
Thanks. Thank you very much. Were you eventually able to make contact and to contact trace everybody who tested positive in the meat factories, or are there ongoing difficulties?
There were difficulties both within the meat factories and outside, and I think they were largely, Deputy, I'll have to come back to with specific information, but my understanding is that we did manage to contact trace everybody within the work setting and almost everybody outside, but I prefer to rely on accurate information, come back to you with an accurate figure. Okay,
thanks very much. Deputy Barrett, you had a question.
Sure. I'd still share on your own question and on foot of my earlier question, I'd still like a bit more affirmative confirmation that we can get additional information about things like workplace occupation in terms of cases, because I think as we open up the economy, that's going to be critical. So I just make that point. But two very quick questions. Did you say, I'm very curious about this, did you say that among healthcare workers there was a considerably longer period of recovery time? Did I hear you say? I'm just curious.
Okay, and the second question, because I'm
okay,
just
sure.
getting people out.
And is that the reason has that got something to do with the amount of viral load that they may have got because of the particular nature of their work, and that is a factor in how sick people get and how long they remain sick? I'm just curious about that. And the second question, because I totally agree with what you said about footprint, right? I mean, we're going to be putting a square peg into a round hole in terms of capacity in come September, if not before. And to what extent do you think for example, issues like understaffing and the consequent long hours that people may have to work, and the stretching in terms of staffing, is a factor in increasing infection rates among healthcare workers, and that
Thanks, Deputy.
very significant. Could you put a figure on the amount of additional staffing and capacity that we need across the health service in order to be able to deal with the pressures we had before COVID and now with the additional need for COVID care?
Thanks.
Very briefly, just to clarify, the prolonged recovery period is, from my clinical experience dealing with predominantly healthcare workers, there's no comparator group there, but it is a much more prolonged period of recovery with people with mild initial infection that you would ever have expected. So that's what we don't know. In terms of the footprint, and I completely agree with the square peg round hole theory. To give you an example of how relatively understaffed we are, I was looking this morning at our GDP compared to Norway. We're probably about 30% lower overall GDP than Norway. Norway has over 100 infectious diseases specialists for a population that's not that dissimilar to Ireland. We would have somewhere just below 20. So if you look at that as an example, if I looked at every single medical specialty, I'm sure that would be the same for nursing specialty, ICU capacity. We are operating within a healthcare system that is, we got away by the skin of our teeth, largely due to the biggest non-pharmaceutical intervention the country's ever taken, which was mediated by the public. We did not get away with this because of the capacity in our healthcare system. To ask our healthcare system and the people within our healthcare system to do again what they've done over the last 3 months would be similar to asking the population to undergo the lockdown again in what they've done in the last 3 months. And there needs to be a recognition moving forward that we can't operate safely with that current footprint and that current staffing
Speaking of
level.
operating safely, we're going to get out here. I suppose the one question I'd have, and I don't expect an answer, is whether we can expect the public to lock down again in circumstances where, you know, it's a question of, and it's a horrible question maybe of an economic response, but you know, 99.5% of people who died had underlying conditions or were over 65, and to what extent you take out the entire economy for that, or that you can afford to. But that's a broader question to be answered by lots of people in this chamber at a different time. Thank you very much to all deputies who asked questions, and in particular to those of you who came in and answered questions and stayed longer than was anticipated to answer them. Thank you very much. We're now adjourned until 12 o'clock.